of give an overview or set the context for empanelment before we hear from the folks on the practice teams who are doing this work. I actually first encountered the concept of empanelment as a young primary care physician in the early 1980s when I joined the group health medical staff and was basically said, here's your panel, here's your nurse, here's your medical assistant, and then spent the next 20 years almost immersed in that world of where it just became very normal to have a list of all your patients and to know when your panel was closed and open. But I left that world in the late 1990s and went into a different delivery system and was amazed at how challenging it was to get other clinicians to really get their heads around the idea of empanelment. So what I'd like to talk about is the fact that the mere act of assigning every patient to a primary care clinician and their team, there are a lot of implications of this. So I think it's important to understand it. First of all, from a population health perspective, it's a way of defining the population for clinicians at a level that they can understand. In other words, it's a scale of population medicine that care teams can really get their heads around. It's also the basis of data transparency. As we get into the world of clinical reporting, what the panel becomes is the reference for our denominators. These are the people we're taking care of, whether it's the entire panel or the patients with a particular condition like diabetes. But I think the thing that we also have to remember is that empanelment is a paradigm shift for most clinicians, and there's a threat to it because there's this implication that we're somehow now responsible for things we can't control. And I think that's where most of the resistance comes, is that clinicians are very aware that a lot of the things that determine their patient's health have very little to do with the drugs that we prescribe or the tests we order or the advice we give, and have more to do with behaviors that happen at home. And so the way I like to think of this is, obviously you can't make a clinician entirely responsible for everything a patient does, but we also can't completely absolve ourselves from any responsibility for the decisions our patients make. It sounds like we're having a bird attack here.
It does, yeah. That's better. I don't know what happened, but that's much better.
We had a visitation from Alfred Hitchcock, I think. But I think what we have to think of ourselves as doing is doing everything in our power to help our patients make good decisions, and that's a way of taking responsibility for as much as we can. So with that as kind of introduction, Qualis Health, as some of you may know, put together a framework of change concepts for practice transformation for value-based reimbursement. And empanelment is one of the foundational core change concepts. The four at the bottom here: engaged leadership, quality improvement strategy, empanelment, and continuous team-based healing relationships. These are the four things that we don't have to perfect them all, but we have to be working on them all and have them all working, all of those four change concepts working together before we can expect to get very far tackling the upper level ones, the evidence-based care, the patient-centered interactions, enhanced access, care coordination, all of which really make up population health and the things we do to achieve the triple aim. So what I'd like to do is just kind of look at empanelment from these other foundational perspectives. What does leadership need to do to make empanelment happen? And I think what leadership's role in empanelment is, it's creating this vision of a culture change, articulating that vision to the care teams, and then making the resources available. And we're going to talk about what those resources are. We also have to create a quality improvement culture where everybody's used to measuring things and testing things out and taking what works and discarding what doesn't, or fixing what doesn't work. And then very importantly is creating a team work culture where we have the culture of teams in our practices. And this means making time for huddles and other meetings for the teams to plan their work, providing the kind of technical support that team members need to do the patient education and motivational interviewing, so we can really work on patients' behaviors effectively rather than just telling them what we think they should do. And then engaging all of the staff, including front office staff, in activities that engage patients in their own care and doing outreach and things like this. And this also means making incentives that extend to everyone and not just the clinicians. From a quality improvement side, as we get more and more adept at using our health information technology and can start to trust our information, means basing our decisions on data and using rapid process improvement cycles to improve workflow as part of our team culture, and then applying these to the care processes that we use in our daily work. But I guess of these different concepts that are foundational to practice transformation, the one that really is most closely tied to empanelment is care teams, because there's way too much work in managing a panel of 1,500 or 2,000 patients. There's far more work in managing that population or that panel than a single individual could possibly do. And what this means is to provide whole person care, whether it's for a pediatric population or adult population. It means balancing acute episodic care with chronic illnesses, with preventive care, and paying attention to health equity issues all the while, and that requires a whole team of people. So what this means is that we have to have a multidisciplinary team together with this defined panel, and then we can tackle these upper level change concepts to do population health and care transitions and all the rest. So operationally, what does this mean? And we're going to get into the details when Dr. Cavens and Dr. Harvey really talk about their practices, but the things to listen for as they're describing what they do are these. One, how do we get started? So, I mean, everybody's getting started at some stage. We have to respect the stage that we're at, and what that, I think, really means is respecting too when you have clinicians who are worried about what this means, you know, and there will be lots of arguments. But far and away the most important thing is to set up a structure that supports empanelment. You can't simply, you know, will it to happen, but people have to be shown exactly how to do it, and the organization has to support it. This means assigning patients, initially using an algorithm. It may be based on who they saw last or who they've seen the most, or who they had the last physical exam with. It'll get some of the patients to the right, assigned to the right providers, but you have to give them the providers those lists and say, which do we get right and which do we get wrong? Then you have to have a process of verifying that with the patients every time they come in or have contact, so that it gets more and more accurate as time goes on. And then as you get this definition of who's in the panel, you have to identify the places where the demand and the capacity for service are not well balanced, and then you have to have policies in place to get those panels right sized. Now, the part of the patient-centered medical homework that we've done at Qualis Health involves an assessment tool, the PCMHA, that you may have heard of. It's a very long, well, it's about an hour's worth of questions that are very helpful to do as a team, actually, to sort of self-assess. But there are 3 that pertain to empanelment, and I think they're worth looking at because they show you where you may be and where you may need to move to next along this continuum. So, and it puts people into these 4 categories, D, C, B, and A. At the lowest level, patients are not assigned to any specific practice. At the next level up, they're assigned, but those assignments aren't routinely used for anything other than administrative purposes. At the B level, though, they're used mainly for scheduling, to make sure that the patient sees their own provider as much as possible. And then at the highest level, not only are you doing that, but you're continuously monitoring the balance and supply and demand of appointments or other care types of services, so that you can close panels and open panels up depending on demand. There's also an emphasis on the data on who's in the practice, particularly pertaining to particular illnesses. So a kind of a registry functionality for that panel. At the lowest level, they're not available at all. At the next level up, you're looking maybe at your patients who have asthma in a pediatric population, would be a good example, but only on an ad hoc basis. At the next level up, you do have reports, and they are regularly available, but only for a very limited number of diseases. And then finally, at the highest level, you're regularly looking at your populations across a comprehensive set of diseases and risk states. And then lastly, I want to look at quality outcomes, because that's another part of empanelment, as I said, that allows you to have clear data definitions. And at the lowest level, it's not available. At the next level, you have reports. Let's use asthma again as an example, but they're not being reported externally. You're feeding that information back to the care teams, let's say, on perhaps who has their asthma severity adjusted or whatever, and then at the next level up, you do have those reports, and you're externally sharing them, but you've masked the identities of the care team. And at the highest level, there's complete transparency. So not only do each care team see how everybody else is doing, but so do patients and external agencies. So that's the type of thing that is exciting, but it's also threatening. And it's but it does show you where the high-performing empanelment practices are. So what is the work that has to go into preparing? One, you have to have some analytic capacity, and it has to be sufficient to do this type of work. You have to be able to identify active and inactive patients and determine their average visits per year. And then you have to try to right-size the panel for each provider based on how many visits they can produce and what the expected demand is on their patient. And the type of structure this requires, it requires the role of a panel manager. You can't just expect it, as I said, to happen. And in groups that are over 10 providers, this almost always requires a centralized panel manager. And if it's a smaller practice, it may be done by a very talented RN or LPN. But again, the task that this person does is to develop and run reports, figure out what to do with patients who haven't fit in, follow trends, maybe open and close. You may have a new provider come in, you may have somebody leave. So all these things have to be managed, and then of course you have to make sure that the data from the panel are properly show up in the registries for management. So there's this cross-functionality work and a very close relationship between the panel management and a population manager who's in a quality improvement role, making sure that everybody in the panel gets the care that the care team is trying to deliver. And this means overseeing a lot of the reporting, particularly for action reports where you're actually reaching out to people who haven't come in, but reviewing the trends and making sure that all of the patients are getting the care that you expect them to. So who gets empaneled? In other words, which providers? The rule of thumb that we use, and this was done in collaboration with the McCall people at Group Health, that any provider who's over 60% FTE gets a panel. For those who are between 50 and 60%, we try to pair them up and to share a panel. And then for those that are less than 50% FTE, they don't have a panel at all, but they basically fill in for the panel providers who do have their own patients, so they'll cover for vacation or CME and things like that. And for nurse practitioners and PAs, our advice is to pair them up with a clinician rather than try to make them carry their own panel. There are other issues that we don't have time to go into, such as how to deal with specialists who are in the clinic or residents. But we do have a number of resources online, and these will be available to you. The SafetyNet Medical Home Initiative that I alluded to is the top URL here. There's also a Coach Medical Home website for those who are coaching. And then the PCMHA that I showed you a couple of examples from is the bottom one. So with that, I'm going to turn things over to the folks that are really doing the hard work out in the field, and I'm looking forward to hearing how they are doing empanelment. Now, I need to turn this over somehow. No, you can do that.
Yep, I'm going to turn it over right now. So I'd like to welcome Kathy Patterson. Here we go.
Thank you so much. This is Dr. Phyllis Cavens, pediatrician and medical director of the Child and Adolescent Clinic in Longview and Vancouver, Washington. Our locations are about 25 miles apart in Southwest Washington. We have 11 pediatricians, 2 pediatric nurse practitioners, and a support staff of 60 caring for approximately 15,000 patients. 75% of our visits are covered by Medicaid. We have been following the patient-centered medical home system of care for approximately 10 years, and received NCQA Tier 3 Patient-Centered Medical Home Recognition in 2011. We are committed to hold 2 lunchtime meetings each week, one for business and one for quality assurance. They are attended by all members of our care team, the pediatricians, pediatric nurse practitioners, clinical care manager, EMR manager, program director, and clinical administrator. The EMR manager, Kathy Patterson, compiles our EMR data and provides our disease management quality metrics and individual PCP reports, plus our meaningful use, outcome measures, business, and quality assurance reports. She will be presenting along with me to provide the background data and tools for our empanelment process. When new patients register at the Child and Adolescent Clinic, they receive a primary care pediatrician. After establishing care, appointments are offered with this pediatrician first, with an emphasis that well child examinations being scheduled with this PCP. Patients can change their PCP at any time according to their preference. Clinicians can suggest a PCP change and message the front desk to update the chart if the patient agrees. Child and Adolescent Clinic has been following these policies since its founding in 1978, but we really got excited about panel management when we were introduced to a tool for quantifying patient capacity versus panel size by Dr. Sue Cressley in 2015. Dr. Cressley also reviewed empanelment at the TCPI Learning Forum in September 2016. We would like to share this empanelment process with you today. Kathy Patterson.
Hi, this is Kathy. I'm the EMR manager at Child and Adolescent Clinic. Before we found this tool I'm going to show you, we use the industry standard for pediatrician panel size, which runs between 1,200 to 1,500 patients per PCP. What I really like about this formula is that it lets you personalize panel expectation by actual visits and days worked, and it's flexible as changes happen in your practice. The first step in figuring out your PCP panel size is to figure out how many patients you can reasonably see in a year, which is your supply of visits. Find the average number of visits per day over the past year and multiply it by the number of days a clinician is actually in the office, and you get your visit capacity. When you do this for each of your clinicians, you get a picture of your whole clinic capacity. For instance, Dr. A here with 18 average visits per day and 138 days per year has a capacity of 2,484 visits. But Dr. D, who sees an average of 24 patients a day and works 184 days a year, has a capacity of 4,416 visits. Next, you need to know your patient demand. Our average pediatric patient comes in 3 times a year, so I divide the number of visits by 3 to get the patient capacity for each of our clinicians. So for instance, Dr. A's 2,484 visits divided by the 3 visits per year means he can take care of 828 patients, while Dr. D, who can have 4,416 visits, can reasonably take care of 1,472 patients. So this shows clinicians A through J with their average visits per day, the number of days they worked in the last year, giving us a capacity at our main office of almost 30,000 visits. And the average patient 3 times a year means we can take care of just short of 10,000 patients. You might notice Dr. F here in the middle, which currently is showing 0 days in the office, but 20 visits a day. This clinician used to work at our main office, but he has moved to our satellite location. So why am I so stressed out? Why do pediatricians have classes on how to avoid burnout? Part of the answer is too many patients and too many problems. This next step compares our patient capacity with reality. I added 2 more columns. On the right side here, first we asked our EMR to tell us the number of patients with one or more visits in the last 30 months who name each clinician as their PCP, and this is our actual patient panel. The far right column shows in hot pink that 8 clinicians have more patients than they can see, and in green we see 6 clinicians who have access in their schedules to see more patients. A burden of too many patients can happen for many reasons, but for us the reasons are a clinician who used to be full-time at 4 days a week has cut down to 2 or 3 days a week, but their loyal patients do not want to switch to another clinician. A clinician such as Dr. F may move from the main office to the satellite office. A clinician may have been established for several years and grew a supersized panel without realizing it. Also, we accept all patients regardless of insurance type, and many patients with Medicaid seek us out. And recruiting new clinicians who share our practice values is challenging. Our clinicians with greater access in their schedule are relatively new or new to a practice site and are still building their panels. And this slide also shows the effect of adding Dr. J, who will start with just 14 visits a day while they're learning our practices, policies, and our EMR. And we'll be able to accommodate 896 patients in their first year, which helps out with the overall burden of patients at our main office. However, we still show a net burden of too many patients, so we hired 2 additional pediatricians to join us in the summer. We need 1 additional clinician just to handle the overall burden of 1,500 patients, and then we need a second pediatrician to grow and accommodate new patients in our area. We found this chart to be extremely helpful when considering hiring decisions. So how does patient panel size affect patient care? It's no surprise that clinicians who have a supersized panel have trouble keeping up with well visits, chronic care visits, and acute visits for their patients. This chart shows the effect of panel size on the ability to keep up to date on well child visits. And we're defining up to date according to the Bright Futures periodicity schedule with an annual well child exam for ages 3 to 20. And we defined active patients as those with any visit in the last 2 years. So Dr. A and Dr. K have significantly supersized panels, and their up-to-date with well child rates are 53% and 48%. But also we see Dr. D and Dr. L with supersized panels, and yet their well child rates are 73 and 75%. And what we found is that they actively encourage their patients to schedule far in advance, and this keeps their patients more up to date. Clinicians with access, the ones in green, our newer clinicians, don't have really great rates for patients newly assigned to them, but we find is what they're often picking up visits for other clinicians who don't have an appointment soon enough for their patient's need. So what do I do with this information? We allow patients to see a clinician other than their PCP for acute illness if the PCP has no openings when the patient needs to be seen. We encourage patients to change PCP if they repeatedly are unable to schedule with their current PCP. Your scheduler might say, I see Dr. A is your PCP, but the last 4 visits have been with Dr. H. Would you like to switch PCPs to Dr. H? Consider adding evening and weekend appointment hours for same-day sick visits or well visits. And when a clinician reduces clinic time from 4 days a week to 3 days a week, or if they're completely overburdened, consider closing their panel or limiting additions to siblings of current patients. And when the clinic has a total overburden of patients, it's time to recruit a new pediatrician to protect the sanity of your current clinicians and reduce burnout. One of our medical home measures is to track visits with PCP. It's our policy to offer appointments with the PCP first, especially for well visits, and then offer other clinicians if the patient's need does not fit the PCP's available openings. We're very pleased with the well visit rate with PCP, with many of our doctors in the 80 to 90% range. Sick visits is slightly different. Every clinician has at least one day off, and sick visits with PCP is a lower percentage. 80% would be a near perfect score. And keeping a schedule with enough openings for same-day sick visits is a constant adjustment and tension with the need for chronic condition recall visits and well child visits. And we monitor that every day and make adjustments. Your PCP panel information can drive improvement in quality measures. When you run your outcome measures by PCP, then you can recall by PCP to improve outcomes. And when you find a clinician that excels in a particular measure, ask how they're achieving that success and copy it to others. We encourage an annual well child visit in the month of the child's birthday with catch-up time in the summer. When individual clinicians have openings in their schedule, recall for well child exams that are overdue. Right now we're recalling for children who will be entering kindergarten in the fall and are behind on their well child visit. When summer begins, recall your middle school and high school students who may need a sports physical and do their well visit. In the fall, recall your patients with asthma to get them set for the school year with an asthma review visit and a flu shot. One thing I really appreciate about our EMR is its ability to turn nearly every report into a recall event using text to cell, email, letter, or a phone call. So get to know your EMR and its recall possibilities to really take PCP panel assignment to the next level. Here's an example of a care plan recall we did for children in foster care who needed a well child visit. We have 362 children in foster care, and we found 104 children who needed a well exam. And we go right from this report to sending messages via a text or email to the foster parent to invite them to call or go online to request an appointment. And with the link provided in the message, it's so much more effective than the postcards we used to send, and the cost is so much lower. Sending postcards cost us over $1 each with supplies, postage, and staff time, and yielded just 17% appointments after 1 month. Email and texting cost less than 5 cents each and yielded 38% appointments after 1 week. I can send 200 reminders for less than $10, so cost is not a consideration in using this great recall tool. Providing care yields data, and that data can drive care through reports and recalls. Our most frequent report and recall conditions are well child visits, vaccines, and asthma. We have the capability to recall for any diagnosis, any lab value, any prescription written, or any vaccine with nearly any demographic filter, and we've used all of those for different purposes. Now, we want children who are sick to see their PCP on the day they call, so we have to leave room for that. But as long as we have enough same-day sick visit openings, we use our care plan recalls to bring patients in for the chronic disease review visits and well child care they need. We recall for the annual well child visit more frequently than anything else. It's a comprehensive Bright Futures visit where in addition we screen for food insecurity, homelessness and harm, screen and refer for developmental and behavioral health needs, provide anticipatory guidance including what to do when the child is ill. We provide a weight-based prescription for over-the-counter Tylenol, ibuprofen, saline sinus spray, and Pedialyte ready for the parent to fill when their child gets sick, and tell parents how to reach us 24/7 so they can receive appropriate care for their child and reduce trips to the emergency department. Thank you for your patience with the details on empanelment, and I'm going to give it back to Dr. Cavens now for a little bit more on this section.
The empanelment approach to cost quartiles is based on our knowledge of pediatric care delivery and finance system that reveals that 1% of children consume 1/4 the cost of care. The cost quartiles then follow the 1, 5, 14, and 80% rule. So the next 5% also consume a quarter of cost and care, 14% another quarter of cost and care, and the remaining 80% consume a quarter of the cost and care. The top 1% are in poor health, have costly, complex chronic disease, and are managed in health homes. The next 5% are in poor health, have complex and chronic disease, and are managed in our in-house care coordination system. The next 14% of patients are in poor health and have chronic medical and behavioral health diagnoses managed by bidirectional exchange of information and community-based care. The remaining 80% of patients have fair health because of the impact of social determinants of health, including poverty, and are managed in the whole child, family-centered medical home. Empanelment makes managing your behavioral health patients easier and better. When the family brings a child with a behavioral health problem to the clinic and sees their own PCP every time, the family builds a trusting relationship and will engage in the recommended treatment course. The empanelment process. Identify your patients with behavioral health diagnosis, form a cohort of those patients, and track them in your chronic disease registry. Obtain an ROI from the parents, write a referral letter, send your records, and ask for the initial consult and pediatric follow-up reports. This allows you to co-manage care with your behavioral health partners and maintain a shared care plan. Track bidirectional exchange of information and follow up if there's no appointment made or kept or no records received. Patients with serious behavioral health diagnosis may require scheduled team conferences to discuss patient progress, prescriptions, changes in severity, ED visits, and hospitalization. Co-managed, coordinated care plans allow the PCP to stay involved in their patient's treatment and decreases cost by reducing duplication and fragmentation. Empanelment makes care plans personal and manageable. We ask our billing system for the most frequently billed chronic disease diagnosis and then brought that list to our QA meetings. We created our own population-based disease registry. We developed an evidence-based care plan for each chronic disease diagnosis and standardized the care plan items such as frequency of review visit, specialty referral, lab tests, surveys, and screenings that are employed to manage that disease cohort. Then we recalled patients with each diagnosis for a periodic review visit to assess their engagement in treatment, progress with their care plan, and address gaps in care. Each pediatrician is provided with their list of patients in each cohort to review gaps in care, ED utilization, non-engagement in specialty care, poor school success or attendance, etc. Empanelment makes care coordination possible. A patient who has a complex chronic condition may be overwhelmed by all the appointments, specialists, DME, travel, translators, hospital follow-up, and community support they need. The clinic can designate and educate staff members to become care coordinators. A PCP can recommend their patient to their care coordinator, who will help the family navigate the health system and get the care they need. The PCP and the care coordinator work together to obtain better outcome for the patient and family. HCA assigns costly, complex patients with chronic disease according to a PRISM score and provides funding for care coordination via a care coordination organization contract for health home services. Each MCO must contract with an organization to provide the prescribed care coordination. The PCP is a high performer in engaging the family in health homes. Next, I would like to introduce Beth Harvey.
Good morning. Did that show up okay?
Yes.
Looks great.
Okay, go. All right. Well, I'm Beth Harvey, and the reason I am working on this webinar as well is because I'm way behind Phyllis. I've been only doing this for about a year. And so I want to share with you some of the little things you can do so that you don't feel overwhelmed and think, oh my gosh, I'll never get to where Phyllis is. But just remind yourself, she's 10 years ahead of us, and they have a lot of things they can teach us so you're not reinventing the wheel, and will make things a lot easier for you. So the key values that I think for figuring out empanelment are, what we found was our quality measures were deeply affected by inaccurate panels. Like, we didn't really know who our patients were. We had people assigned to us that had never been to us, that we didn't even know were assigned to us. We had people who were getting reports on who had never been in the clinic, and we just really had to try to figure out how to get control of that and have workflows and processes. So as people moved into the clinic, we had their records, everything was complete, and as they moved out, we were tracking that, inactivating them, and forwarding their records, and then also doing that with other systems like the immunization information system and things like that, so that we made our panel more accurate, so our data was more accurate. We also found, because of that, we're able to then track specific patient populations and actually pick what quality work we want to do, because you can see a little bit better where your gaps are. We did find there were a lot of ghost patients, so there were people assigned on our panels with our Medicaid plans that we had never engaged with, and there are ways you can address that, either partnering with the managed care plans to have them reach out and connect them or reassign them, and then you also reaching out to them with best data. We have been trying to be very proactive when we get ER reports that are patients that have never been to us. We actually will call the ER medical social worker and say, we don't know who this patient is, we keep getting these reports, where are they actually going, and making sure that that gets remedied so that we're not getting things for patients that aren't actually in our care, especially if they're repeatedly using the emergency room. Knowing your panel really can help you figure out as a clinic too if there are things that are different. One thing we found was that our combo 10 rates were low just because of the influenza rates in our clinic. And so we're trying to figure out for next flu season, are we going to be messaging differently? Are we going to be needing more clinics? Or how are we going to address those needs where there are a lot of our patients who are not getting influenza vaccine? And we've also done this as a clinic. How do we change how we message HPV? How do we focus in on that as a work that we all are doing together? We also found that the immunization registry, we had to update that to be able to use those quality metrics. So in our workflow, as a patient moves out of our clinic, we also inactivate them on the IIS. And as they move in, we make sure that it's accurate and updated. And then we also know now how to recall certain populations at different times of the year. So we are doing asthmatics late summer, early fall, so we can review their asthma action plans before illness starts, make sure they get their flu vaccine and they're up to date on their checkups. And you can do this for different populations as well. And then we've really found, we didn't realize how low our well child visit rates were. We thought they were really good, but under 2 they were really good, but other ages were not so good. And so we've started during different times of years focusing on recalling different populations, and that's been really, really neat to see that. And then also making sure that as we add new screening protocols and things, that there are good connections to the community. So before we do, let's say, postpartum depression screenings, we already know what the resources are and how we're going to refer people so that we have a really smooth workflow and system when we implement a change. ED utilization, we've been able to focus in on working with the managed care companies who is overutilizing the ER. We've been tracking in our clinic who's going to the urgent care, when did they call triage first or us first, and we're honing in on educating and supporting the families that are overutilizing, and we're starting to see that that is impacting a decrease in that. And I think knowing what your resources are, do you yourself provide urgent aftercare hours, or do you know where the resources are that you prefer your patients go to, and are you sharing that with them? And then obviously special populations, this just enables you to provide the best care for some of those 1% most complex kids. It also helps you work and know your community resources and partner with them, and really start helping working on your mental health issues. So just know the more you understand your strengths and the challenges of your patient, you'll be able to use your panel, and kind of as you understand it better, you'll be able to focus your work better. Just start with something really simple, whether it's just a workflow change of working on no-shows, or working on how do you get people enrolled in your practice and out of your practice as they move. You can talk to families and survey them about what they want. Do they want early hours? Do they want walk-ins? Do they want after hours or weekends? Group classes? What do they need? And you can start meeting their needs as well. And then I really like the idea of what kind of reminders do they want and respond to, because that's really going to help you with your engagement. And then basically this just allows you to figure out in your team with the staffing you have, how can you focus on your entire panel throughout the year? How can you schedule consistent time for people to do this work? And how are you going to communicate what you learn with your entire staff? And of course, I have not totally figured this out yet, and it's a work in progress that we keep trying different things. But we've definitely seen improvements even in just a year with sort of focusing in on these small changes. And as you track them, you'll really start to see progress. So we'd love for you to share what you learn, especially if something's been really helpful, and give us feedback when you have resources, if they were your favorite things and the most helpful, and what order was helpful, and we'll start sharing that with everybody participating in the grant. So thanks.
Thank you. Thank you, Beth. Thank you, Dr. Harvey. Thank you, Dr. Cavens and Kathy Patterson, and thank you, Dr. Hummel, for being here today. This is a great opportunity when you have these experts on the line. If you have questions, you can just type them in the chat box, and I will. So yes, absolutely. Somebody asked if they could get a copy of the slides, and I will email everybody that participated in the webinar a copy of the slides today so you can see that. Any other questions? Okay, and it looks like we have a hand raised. Let's see. Okay, great. Thomas Heron has a question. So do you want to go ahead and type that in the, here, let me unmute you. Okay, Thomas, what's your question? We can't hear you. Maybe try typing in the chat box.
Hi, can you hear me now?
I can totally hear you. Yes, I can hear you now. Yes.
Oh, good, good.
Yep.
It helps if I take off the mute. We run OP as our system also, as I think Beth and the clinic down in Vancouver does. Is it possible to have our data people visit and see exactly how those reports and recalls are generated? Are they open to having visitors come by?
That's up to the presenters. Are you open to having visitors? Dr. Cavens or Dr. Harvey or Dr. Hummel, are you open to visitors coming by to see your empanelment in practice?
Right.
Yeah, I am, and I do not have OP. I have PCC, if that makes a difference.
Okay.
All right. This is Dr. Cavens. We're considering with the grant that we will have meetings of practice administrators or EMR managers, either like we're doing today with the chat back and forth, or a visit, which is certainly possible. But by forming groups according to what EMR you're using and sharing lessons learned. So yes, there's many ways to approach this shared learning.
Great. I would appreciate it.
Great. That's wonderful. It's a great question. Are there any other questions? Go ahead and speak. You can also raise your hand, which is very exciting.
Let's see.
Let me see if there's anything in the chat box. Oh, here we go. Here's a couple. Dr. Sam Kablawi and Francie. So Sam, what is your question?
Hey, good morning, everyone. I just wanted to find out what EMRs are you guys using that allows you the capability of doing those recalls?
Well, this is Kathy at Child and Adolescent Clinic. We've been using Office Practicum for a little over 8 years.
Oh, that's the OP. Okay, gotcha.
Right. So nearly every report is a recall event with OP.
Yeah, and we have PCC or Physician Computer Company, and we can do the same thing on ours.
Okay. Do you know, I mean, our new parent company in the summer was going to be Multicare, and I guess we're going to be going with their version of Epic. Does anybody know anything about that or how that system works? Or
So I have some experience with Epic, and they do have a very robust system of reporting at panel levels that includes a number of tools that can keep patient lists that then translate into both chart notes if you take action, as well as outreach functionality. So I think going with Epic, you'll have a very strong tool set to accomplish that.
okay, thank you.
In fact, Kaiser, which is sort of, and Group Health, which is now part of Kaiser, that really sort of established the methodology for empanelment, were very active in helping Epic develop a lot of their population management tools to support their empanelment.
Okay, great, thank you.
And Francie, Dr. Chalmers, she has a question. Oh, Dr. Chalmers, do you still have a question? I see your hand raised.
Yeah, I'm sorry.
Oh, no worries.
My hand is not raised.
Oh.
And I don't have a question.
Oh, okay. Sorry about that.
I didn't raise my hand.
Okay, sorry. That's always awkward when somebody puts you on the spot like that. Are there any other questions? If you're not comfortable speaking, you are welcome to put questions in the chat box. And it looks like, oh, thank you. Kathleen Clark had a great question. How can your practice facilitator help you? So if you make an appointment or reach out to your practice facilitator, or next time they're in your practice with you, they can help you several ways. They can meet, they can help you go through your patient panel and see which patients you see on a regular basis and which patients you don't. And they can also help you with this formula and figuring out how many patients you're actually capable of seeing. And so you can kind of start to work from how many patients am I capable of seeing, how many patients are on my panel, and so on and so forth. You can also partner with your Molina representative who can show you how to get into your Molina portal to see how well that matches up with what your EMR says you have. And yes, thanks. Also, great question. You will be emailed the slides by the end of the day today. Okay, and it looks like we have some more questions. It looks like Brenna Lewis, is your hand raised on purpose?
Yeah, can you hear me?
Welcome, I can.
Awesome. I was just curious, I'm so sorry I came in really late. I was at the hospital.
No worries.
Does anybody else, so our Molina patients are actually delegated completely to the organization that I work for is Managed Care Organization, which adds an added layer of complexity for empanelment. I just was wondering if anybody else's clinic had a similar situation and if they had any workarounds. We've got Molina talking to our Managed Care Organization and we're working on it, but I just didn't know if anybody had any breakthroughs with a similar situation.
Does anyone on the call have a similar situation like that that they want to talk about, or our presenters, do you have an example that you want to talk about?
Well, this is Jeff Hummel. I'm very well aware that this is a growing problem, and as value-based reimbursement becomes more common, the necessity to reconcile what the payers are using to attribute patients and what we as clinicians use is becoming more than just, you know, an annoyance. It's becoming really crucial. And so I'm aware, I've done some work with some of the FQHCs in California, and that is a overwhelming need to solve that problem. So you're not alone. I think for now, I mean, obviously we need some sort of analytic capacity that can take a list from all the different payers. I mean, it's great if if the majority of your patients say are from Molina, but there's other payers as well, and the same problem exists. So with a fragmented system, you can very quickly, it turns into an almost unmanageable problem. And that I think is one of the greatest analytic needs we need, is to be able to identify those people where there is a mismatch, and so that we're being judged on the care we deliver to somebody who we're not even aware of, and they don't come in. Right now, I think that's one of the tasks that
Oh, you're kind of cutting out. Okay, now we can hear you. Dr. Hummel, did we lose you? Are you still there? All right. Well, is there more? Let me check down here to see if there's any more questions in the chat box. I do not see any. Okay, and if there is not any questions in the chat box, and is there any questions from here? I don't see any more. So I will send you a copy of the slides, and if you decide also that you want to be talking, or you want to reach out to your specific provider, you're welcome to do that as well. So we thank you for being part of our webinar on empanelment, and stay tuned for more to come in the future. Thank you very much.
Thank you.
Thanks.
Thank you.
Thank you.